welcome to Cardia. I'm Mark McDonald, and this is your School of Hearts and Sciences. During this series of programs, we get an opportunity to take you into the operating rooms and the catheterization labs of the Prairie Heart Institute at St. John's here in Springfield. And the only way we can do this is by the cooperation and access that we get from the patients at Prairie Heart and the doctors and the staff. And we have some of those doctors with us. I call our first doctor the Dean of Hearts and Sciences, Dr. Kriegh Moulton. He's the Executive Medical Director of Prairie Heart Institute at St. John's.
And you can't say it enough, Prairie Heart Institute.
There it goes. It rolled right off that time. And he's also the, like I said, the Dean and the Executive Medical Director and an interventional cardiologist.
Correct.
And during this program, we're going to learn what an interventional cardiologist is as opposed to an electrophysiologist.
Right. And the difference simply is a different union. I'm a plumber, and Kriegh Moulton, who is our visiting professor at the University of Hearts and Science, is an electrician.
Okay, so you're in the plumbers union, plumbers and pipe fitters?
Plumbers and pipe fitters.
Okay. And the electricians union.
That's right.
Okay. What sort of issues do you deal with?
Well, we deal with heart rhythm disturbances, and for the most part, people who develop heart rhythm problems have either very rapid heartbeat or very, very slow. And probably the more common is the rapid heartbeat, and it ends up causing a lot of symptoms such as palpitation. Patients that have really slow heart rates generally complain of fatigue and shortness of breath and inability to engage in the usual activities. So,
but they can also pass out as well.
Occasionally.
Right.
So you two, would you ever see the same patient?
We would share patients. Oftentimes, patients can have both situations, particularly as you age. And there are certain diseases that overlap. For instance, atrial fibrillation is a disease that I see an awful lot of, and a disease that Kriegh sees an awful lot of. The truth is, patients with coronary artery disease, the plumbing side of things, can oftentimes develop as they age, slow heart rates, and I need to refer them to an electrician to have a pacemaker put in. In lots of groups, a cardiologist will do both. In our group, because it's so large, we sub-specialize, and Kriegh an expert along with the rest of our electricians at the electrical system.
How many electricians are you have a large, like say, a large group? You have the largest heart hospital in this area.
Oh, for sure.
And so, how many electrophysiologists would there?
In total, we have
Six.
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 I was going to say 7, but I would have been wrong.
Yeah, and we had the opportunity not only to tape some of your procedures, but also one of your colleagues, Dr. Isa's procedures. We're going to see some of those, both of those today as we go through the program. But let's get into the cath lab, okay? Let's get in there where you were earlier this week, putting in what you called a very simple procedure, but for most viewers, watching a pacemaker go in isn't simple at all. It's something they've never seen before. But let's take a look at how you start here, Dr. Moulton, because as you can see, you start, of course, with an incision.
Right. Right after giving some local anesthetic to numb the skin, and the patient's also been sedated, so they're really not aware of what's going on. An incision is made below the collarbone, about 2 inches or so below the collarbone. The incision's about 2 or 3 inches long, and the initial incision is made with a scalpel to cut through the tough skin, and below that the tissue is soft and can be cut with that device that you see there. It's called an electrocautery device. That
we learned about that last week with Dr. Christie.
And that's a burning device, isn't it?
That's right. And so it cuts, in effect, using current that disrupts the tissue.
What are you doing there, Kriegh? You just stuck a vein, it looked like to me.
Okay, that was a needle that was put in the subclavian vein, and through that needle I'm advancing this wire. And you can see on fluoro right there the wire is going down in a big vein called the superior vena cava, and that's the entrance to the heart.
Now that looks like an X-ray. Is that what that is?
Yes.
Okay, and you call it fluoro, but it's an X-ray.
Right.
Okay.
And the other interesting thing, just to quickly interrupt you, is that I don't know if you noticed the wires in the chest. That patient has had previous bypass surgery, so you see the intersection between the plumbing and the electrical system.
Okay.
So this is a dilator sheath combination. It's the way we can get into the vein and advance this lead, this electrical lead, without causing a lot of trouble. And there it is, the lead I'm sort of showing the tip of it there. It's got a little pigtail on the very tip of it. You can't see, but that's going to bury itself into the interior of the heart. And so I'm advancing it into the sheath, and it's going to go right down into the superior vena cava, and then we'll finagle it into the right ventricle. That's where its destination. And the tip of that is going to be secured into place.
Now, I've watched Kriegh do these things, and it's about this fast. In other words, this is live footage, probably unedited, and I think Kriegh can do these in about 5 to 10 minutes, is what we say, skin to skin.
Now, are you getting near your destination here?
Right, I'm trying to get that tip to slip into just the right spot. That's a little too high, and I'm going to advance a stylet that's inside there to get the tip to drop down to a little bit lower position.
Now, how did you determine in tests before where that lead was going to need to go?
Well, you become facile with the movement of the lead. You understand as you watch it take place on fluoro and what it feels like. You can, learn how to get the lead tip to go where you want it to go. It takes some time to learn how to do that.
You knew that it needed to go in the ventricle, though.
Right.
Did you say the right ventricle?
Right.
Okay.
And we have ways of knowing by having a certain view of the heart where we are. And there are little clues that you can see. It's fluoroscopy, which means that you're watching the beating heart so that you can see things that are clues to where you are and how to navigate from one place to another. So there is after a while of doing this, there's a very characteristic appearance that you're targeting. Some people have different anatomy, and you end up positioning the catheter in a different location, but in the end, we have to test that lead in its position, in its final position, to know that it's secure and appropriate.
Now, in this case, as in most pacemaker cases, you went in here, right, to make your little pocket where the pacemaker is going to go, and it's from there that you're taking the lead down into the heart.
That's correct.
Okay. Now, one of the things that's interesting, because you pointed to your left shoulder there. So in Central Illinois, we would always ask the patient before we were going to put a pacemaker in the left shoulder, do you shoot?
Wow, yeah. Now, bang, the recoil.
And most people shoot from the right. So it's the right side that a shooter would want to avoid. But the flip side of that is a lot of patients, most patients drive. And the shoulder harness, if you're a driver, is going to be going over the right, going over the left shoulder. And so that sort of frees up the right side so that there's no annoying rubbing on the device.
It could be uncomfortable, I guess.
That could become an issue over time.
But in the case of a shooter, you're talking about, I mean, could you, with the recoil, could you dislodge the lead or something? I mean, is that possible that something like that would happen?
There are people who, we call it twiddler syndrome, who actually play with their pacemaker, just sort of inadvertently, sort of this repetitive, and you can twist these things around.
Oh, man.
Yeah.
And it can pull the lead out of the heart and drag it into the pocket. But luckily, we don't see that too often. Most of the time, the leads are secured. It might not have been shown in there, but once the lead's in its right place, there's a sleeve that fits down, and you secure the lead with some suture material so that it's not easily pulled out.
Let's take a look at a pacemaker. When we look at clip 2, we say the first thing you do is you show us one of these items, and this is what's going to go in that pocket.
Now,
that we just
what kind of pacemaker is this, Kriegh?
That looks like a dual chamber pacemaker. That one is a single chamber. That's there's only one lead that's being inserted into what's called the header. It's a plastic receptacle for the lead.
And they're remarkably small. I think a lot of patients feel like cosmetically this is going to be an issue for them. And we talked about a pocket just a minute ago, and that's what you're doing there. You're slipping that pacemaker into this little pocket that you created surgically.
And look how tidy that is. I would think, from just thinking about building a pocket like that, that it would be kind of a mess, but it's just tidy. It's just like sewing up a piece of material.
Right. You don't see any bleeding going on there.
Okay, now what is this device?
That is a programming head. And what it's doing, it's communicating with the pacemaker so that the device representative down at the other end of the table is able to now check a few of the parameters that we look at to make sure that the lead is in a good position.
Oh, okay. And I think that's what we're going to see next, is that we're going to see a fellow checking a screen here just to see.
That's
I guess
right
this is
there.
what
That's
he's
the
doing.
Programmer.
Mm-hmm.
And this is all done through what's called radio frequency transmission of information.
Wireless.
Wireless, that's right.
Mm-hmm. And so apparently everything looks normal, right? It sounds like it looks like everything's going off the way it should.
Right.
And this is a different test or a different result of a readout.
Well, this is the electrocardiogram of the, some of the leads are not quite secure, and so we see them all over the place. But that's what we're seeing, is paced rhythm.
Yeah.
Looks like you've got some pacemakers on the
we
table.
Did bring some in, or Kriegh brought some in. And you can see, we'll take the little one and the big one, because these have really have changed through the years, haven't they, Kriegh? Or are they both real modern?
Well, they're comparable to the current. I don't know about the names, but the what you have on the left, in your left hand, is a defibrillator, and the right hand is a pacemaker. And the difference is that the larger device is designed to deliver a shock to the heart in a condition where the rhythm is extremely fast. And that arrhythmia is called ventricular tachycardia or ventricular fibrillation, and the device is designed to restore rhythm back to normal. That type of heart rhythm problem is what causes cardiac arrest. And a lot of people think that when you have a cardiac arrest, you've had what would be termed a massive heart attack. But it's not. A heart attack relates to a blocked artery suddenly, and a lot of muscle tissue in the heart is suddenly without a blood supply, and chest pain results. But this condition that causes a cardiac arrest is actually a very rapid heartbeat problem.
So this really acts like an emergency room in your chest.
Yeah, it's a defibrillator like you see, you know, on TV.
On emergency.
In ambulances, and instead of there being two large paddles on the outside, there are two paddles on the inside. One of them's the device itself. The other is a similar lead that you saw earlier that has a larger electrode near the end, that between the device and that lead, a large amount of current is delivered, and it shocks the heart back to normal.
Earlier, one of your colleagues, Dr. Issa, had a patient who had atrial flutter, and we got a chance to go into the cath lab while he was doing an ablation procedure. So, would you talk us through that as we look at the next clip? Because this is fascinating to me, because what he was actually doing is showing how he was going to map the heart and find out where these where the source of this arrhythmia was, and you can see he's got all kinds of readouts there in front of him.
What's on the top right, Kriegh?
Well,
the
colorful image there is what's called electroanatomic mapping, and it's a very handy way for us to understand how a tachycardia is taking place. And basically there are two. One situation is where a spot inside the heart is emitting an impulse repetitively.
Like a lighthouse.
Exactly, like a beacon. And the other is where an impulse, this electrical impulse that travels in the heart, may circulate in a large pathway. And that's what happens in atrial flutter, like Ziad is fixing. The pathway can be defined by this same electroanatomic mapping system as it would to define the mechanism of a focal arrhythmia. So using that, we can tell what's going on. And basically it involves having a catheter inside the heart. The tip of the catheter is metal, and the system that we use involves a magnetic field that involves having some magnets around the table. And using that, the system can detect where the tip of that catheter is at any moment, and it can follow it. And so over time, you can, by moving the catheter, construct a...
Is that what he's doing now? Is he moving the catheter when he holds that?
Right. I don't know whether he's doing the ablation or whether he's mapping. I suspect he's delivering the current. But if you move the catheter around the heart, you can create the shape of the right atrium, and that's sort of roughly what those colorful images are up there. The fact that there are different colors indicates that red means that it was a relatively early moment in time during the tachycardia. purple or blue was a very late moment.
So it's sort of like a racetrack.
Yeah.
And he's mapping where it is in the
Where
racetrack.
is it
Corner
coming
1,
from?
corner 2, corner
Right.
3, corner 4.
And
Because I know you're a big NASCAR fan.
I never thought of it that way.
once that's
interesting.
done, and one defines what the mechanism is, we know where to go inside the heart to eliminate the tissue, to burn the tissue, in effect, to make it not happen again. This type of flutter is a very common type of arrhythmia, and it turns out that inside the heart it's the same place in everybody that we target to eliminate the arrhythmia. We position the tip of an ablation catheter in the same place in everybody, and you burn that tissue. And you're really creating a second-degree burn. It's a very controlled burn. And as soon as enough scar tissue develops, either the arrhythmia terminates or we get an indication from those electrograms what that we've reached.
And the advantage of doing an ablation, because we have drugs to control these arrhythmias, either atrial flutter or atrial fibrillation, but the advantage is patients would not have to take a lifetime of medications.
Right. The idea is to cure the problem. The cure rates are not 100%, but they're really very high. For atrial flutter, the cure rates, I think, are 95, 98%. That means there's only a 2 to 5% chance that the problem could recur. It's possible, but unlikely.
Let's pick it up again in the next clip, because I noticed I was in on this procedure, and I noticed that the patient was feeling the ablation, and was, you could hear the patient moan when the heat was applied.
Right.
So somebody might wonder, well, I thought they were unconscious, but the patients aren't truly
They're
unconscious.
they're under what's called moderate sedation, and that you're probably not free from feeling what would be called deep visceral pain and respond to it. But the patient's never going to remember that. They'll have no recollection that such a thing was experienced. And the reason that happens here is because this area where we're ablating is probably just a few millimeters from the diaphragm, which is rich in nerve fibers that allow the
very
sensation.
Sensitive place, yeah.
Yeah.
Very
Otherwise,
sensitive
inside
place.
the heart, there are no nerve endings. You can't feel, if you were to cut the heart from the inside or burn it as we do, you can't feel that. There aren't any nerve endings in there.
In almost every case, when you gentlemen are both doing, when you're doing procedures, Dr. Mischkel, your patients are never, are they ever unconscious, or are they always in that twilight state?
Well, the aim is to keep them, depending on the complexity of the procedure, to keep them in a light to moderate sedation twilight state. If increasingly, as we do more and more complex procedures in the cath lab, we bring in anesthesiologists, nurse anesthetists in the cath lab to allow us to take patients deeper and safely monitor them to make sure they don't stop breathing. They take over the breathing functions and help us monitor those patients. But certainly when I started out, you'd never have an unconscious patient in the cath lab, but as we oftentimes some of these procedures are 2-3 hours, and we may even put the patient on a breathing machine like you do in the operating room.
And that would just be, why would you take that precaution?
Well, because you can give somebody too much sedation, and while Krieg's concentrating on what he's doing, that patient could slip into a state where they can't breathe on their own. And obviously that's something that we want to avoid and that we are trained to avoid, and that's especially for anesthesia.
And atrial fibrillation ablation is a much more complicated procedure than this one. We have patients under general anesthesia. They're intubated like they were having general surgery because we don't want them to move. This device that I was referring to earlier, where we're tracking the location of a catheter tip in space, if they moved, that location would suddenly be shifted. It would be like moving this table over an inch and you're now lost. We're interested in millimeter by millimeter accuracy of where that catheter tip is located, and we can't miss that. So we have to sedate, we have to put those patients under general anesthesia.
We also saw earlier in that last clip, we saw Dr. Issa also on the screen were these series of green lines. And I noticed there was one point where those green lines just flattened out. They were irregular and then they flattened out. What was that symbolic of?
Well, in all, it could have been any one of a number of things, from an artifactual mistake to the fact that at that moment the tachycardia that he was ablating terminated. We can ablate these arrhythmias often when a person is in the tachycardia, And at the point at which you burn a critical mass of tissue, the arrhythmia comes to a grinding halt. It happens in a heartbeat. So that probably is what that was.
And then typically the heart would restore rhythm on its own normal rhythm, or you might need a pacemaker if it...
Well, frequently after a tachycardia terminates, there is a pause, maybe 2 seconds, 4 seconds, but that's exactly right. The inherent behavior of the heart, automaticity, makes a rhythm always there. It's rare for there not to be a rhythm.
Okay, let's take a look at the next clip, because this is another pacemaker procedure, but this one, oh no, these are the green lines that I was talking about now. These are, and I think you were right in that he ended the tachycardia because he was very pleased with the outcome.
Right.
And you can see that, I think we get a little closer look here. You can see that on the top screen, they're jagged lines, and then they flatten out and they just smooth out. Those lines there are very, very.
Do you see how we have two cameras? We have a camera coming in at 10 o'clock and a camera coming in at 2 o'clock there. So this is in a special cath lab we'll call a biplane lab, where when we use the X-rays fluoroscopy, we can get two different looks at the heart without rotating the camera from place to place.
Okay, very good. Yeah, he's pleased with that. Patient's going to be well. Okay, I mentioned that we were going to go ahead and move on to another pacemaker procedure. This one is a double lead pacemaker procedure, and I'm sure you've done these all the time, but they're a little different because Dr. Issa was putting in 2 leads, and they have to go to different areas of the heart, don't they?
The one lead goes into the upper chamber, the right atrium. The second goes into the lower chamber, the right ventricle.
So there you see the header that Kriegh was talking about before, and there's 2 places for 2 leads.
And he's putting in the upper chamber right there. It's on the top of that header. That's to make sure that the upper chamber and the lower chamber, the dual device, are operating in synchrony with each other. So what the lower chamber does follows what the upper chamber does. So you have the proper sequence of activation that sort of replicates what happens under the normal circumstance.
And again, the pacemaker is really not any bigger, is it?
Not much, no.
They just keep getting smaller and smaller, don't they?
Well, I will tell you, the smaller the pacemaker, because the volume occupied by the components inside is 80% battery. The smaller the pacemaker, the less longevity. The battery will deplete sooner. The bigger the battery, the longer it lasts. So they do have pacemakers and defibrillators that have larger battery capacities to allow the device to be lasting longer. Most people don't want to come in just a couple of years and have their generator replaced. They'd rather, you know, wait many years before that happens. So
now this sewing that he's doing now, is this to keep that from moving around inside the tissue there?
Right.
Is it?
It's to help that twiddler problem.
So he popped it into the pocket. He sewed the leads to the underlying tissue to make sure that it stays fixed. And then he's going to close that pocket. And again, the other thing to notice is, as you observed before, there's really very little blood. This is not a very painful procedure, not a very bloody procedure.
I guess they recover pretty quickly, don't they, Kriegh?
Well, almost all the patients that I implant pacemakers, I send home later the same day.
Is that right?
So we've, the same way in a lot of things now, we are sending patients home the same day.
Well, that's, you know, that's, I guess, because you all have got so good at entering the body without having to cut into the body. It's remarkable what you can do through the venous system.
And patients want to go home. They do not want to spend the night if they can avoid it.
We did get somebody emailed us a question when they knew we were going to be doing a show about pacemakers, and they said, well, how long is that going to last? How long
procedure?
No, the pacemaker.
Oh, okay. So most of these devices are going to last anywhere from 7 to 9 years. It depends on how much they're used. It depends on a lot of features that consumes electricity by the pacemaker. That is an effort at trying to make diagnostic information available to us. So the device is not just there to deliver pulses every 60 times a minute to make a heartbeat, but it's there to constantly surveil the heart rhythm condition to make sure that any one of a number of rhythm problems isn't taking place, or it could be that it's in a surveillance for abnormalities that can develop in the device that we would want to know about and warn us ahead of time.
And in fact, you have patients come back on a regular basis to monitor the status of their pacemaker.
Well, today we have home monitoring. It's sort of replaced the old magnet and telephone conversation that takes place to check that battery status, and that's all that did, was to let the person know that it was near time to replace the generator. Today we have little devices that sit by the patient's bedside that will periodically download the information from their pacemaker or defibrillator and send it to our computer service in the device clinic, and we can take a huge amount of information from the device as to what's going on. Well, that costs energy in the form of battery voltage, and so the more that's involved, the shorter the lifespan. But we can program a lot of these things on or off.
So in the 7 to 10 years that this person has the pacemaker, that 7 to 10 years is up. The batteries have to be recharged. Do you just put a whole new pacemaker in?
Right. These things are sealed. You can't open them. It would cause a catastrophic, chemical reaction and infection. So you just disconnect the leads through little set screws and reconnect the new device to the.
So the leads stay in.
The leads stay in, and so all you have to do is take the thing out and reconnect
the new device.
Wow.
Sometimes the leads break and we have to remove the leads, and we now have some technology that allows us to do that reasonably safely that involves laser.
The nice thing about what Kriegh does is that batteries are always included.
Wouldn't that be awful to find out?
Patients can rest assured the batteries are always included.
You didn't buy your batteries. You got. Is there anything new coming down the way in electrophysiology? Are you looking at anything groundbreaking?
Yeah, in regards to pacing, there is probably within the next year or two a device that is delivered inside the heart through a large sheath. That's just a big tube that allows us to scoot this little device down inside the heart, and it can be deployed or delivered into the chamber of the heart, screwed into place, and it is a fully contained pacing device where there are no leads, and so we refer to it as a leadless pacemaker system. And the type of battery that's used to power that is a different one than these devices contain here, but that's
the advantage for that would be no cutting, no screws, no leads, no need for revisions per se.
Boy, we have come a long way, and I can't get you both started on that because we only got 1 minute left, but even in my short time of studying this field, which is about 10 years, it's changed remarkably, and it's all for the good. It's all for the good.
Absolutely.
Dr. Mischel, Dr. Moulton, thank you so much for being
welcome.
here. In the coming weeks, we'll bring you other experts from the Prairie Heart Institute. We'll be looking at peripheral vascular disease, among other things, and invite you to join us on the next Cardia, your School of Hearts and Sciences. See you next time.
For a DVD copy of the program you've just seen, send 1995 to Network Knowledge, P.O. Box 6248, Springfield, Illinois 62708. Be sure to include the program name, subject, and when the program aired. You can also order with your credit card by calling 800-232-3605.